So in an ideal world, all your patients would get their heads onto the slit lamp and would get their pressures checked using Goldmann applanation tonometry. But life's not like that sometimes. People may have scoliosis, they may have bad Parkinson's, they may just be a bit on the large side. So sometimes it's not easy to do Goldmann applanation tonometry. And you want to have another technique which is of similar status and similar standing and equally easy for the patient to do. And so in those cases, I reached for my Perkins. And it's the same principle, the same technique, but rather than using it on a slit lamp, use a handheld one, sometimes with the headrest, sometimes without the headrest. The same basic technique, except using a handheld instrument, and just as valid, just as accurate. And again, using the one-touch technique, much less likely to cause any damage to the eye surface. So the first thing we'll do is put some anaesthetic in the eyes. So if you look up towards the ceiling just now, a wee dribble of that in. Give you a wee tissue, because that nips a bit when it first goes in. Disposable prism heads again. Get it into position. And just the same as the big one, we're going to insert the prism head into the holder, making sure that the wee flat bit is at the top, so it's sitting nice and flat along the horizontal. But he set the instrument up to read at 18 like I did the last time on the Goldmann. That's my one touch technique, that's my safety point. And if you look up towards the corner of the room up there, using the brow bar, get the instrument position just to drop in place, pull the top lid out the way, almost touching the eye, bring yourself across, drop it into place, check the Myers, and that's almost exactly correct. So pressures are about 17 in that case. Nice and straightforward, nice normal pressures.
Okay, Lisa, I'm just going to carry out some simple eye tests on you today. We're just checking how your eyes line up. There's a picture up there in the wall at the moment. Is it clear or blurry as you sit at the moment?
Blurry at the moment.
Can you try and make it clear for me?
Yes.
Is it clear now?
Clear now.
It's clear now. And if you relax your eyes, has it gone blurry?
Yes.
Okay. So what I'm going to do is I just want you to watch the picture for me, and if you could just make it as clear as you possibly can. You can see there's a very large left esotropia. When I cover the right eye, the left eye straightens up to take up fixation. And now she's relaxing and she's letting the picture go blurry, but if she makes it clear. So Lisa doesn't have diplopia when she squints, which also tells us that she's had this from a very young age and she's learned to suppress when her deviation is manifest. If I now ask Lisa to actually read the letters, we can see that the accommodative demand's increased. If I do that, now she's fixing with her left eye and she's back to fixing with her right eye. Cover the right eye, the left eye moves out to take up fixation. She's now, can you get it clear again? She's actually managing to hold it clear. She's showing considerable binocular vision control. However, it doesn't take much to get her to break down.
Measuring the pupillary distance in paediatric dispensing is essential. Doing it quickly and effectively using positive communication is paramount. So, Lauren, I'm going to put my ruler on your bridge of your nose. Now, look into my open eye, Lauren. Lauren, look into this open eye. Well done. The crest height is a very important facial measurement. In young children, you would expect this to be very low, perhaps about 0, increasing with age. The measurement is taken from the crest of the bearing surface of the nose to the lower limbus. Lauren, I'm placing this on the bridge of your nose. It's always advisable to do both sides in case there is a difference. If there is a difference, we would generally do the average between the right and left side.
This presentation concerns effective eye testing for children with autism spectrum disorder, or ASD, and gives some helpful hints about what clinicians should know and do when testing children with autism. My background is in clinical visual research in children with special needs such as Down syndrome, cerebral palsy and autism, and I particularly as an optometrist want to understand visual function and when developmental disability makes things go wrong. I want to maximise visual potential and I want to make sure that we effectively communicate with other healthcare professionals and those in education and parents about the status of vision in special needs. This work today really arose through interest I had in understanding more about autism and about the visual concerns.
I did a placement here at Wascott as part of my qualification to become an independent prescribing optometrist.
I decided to do the teach and treat clinics because I wanted to see how patients are managed in the hospital and also just to build relationships with the ophthalmologists as well, just to develop my knowledge and see if there were things that I could manage and practice more rather than having to refer.
Yeah, I decided to do the teach and treat clinic because I really wanted to get the opportunity to get hands-on experience with patients in a fabulously equipped centre and with very approachable and highly skilled ophthalmologists who were able to steer me in the right direction.
The one-on-one supervision that we had from a consultant ophthalmologist was hugely beneficial. We had the opportunity to examine patients independently, arrive at a provisional diagnosis and then have expert input from one of the very approachable consultant ophthalmologists here at Wascott.
I enjoyed the interaction with the ophthalmologists. I also enjoyed the interaction with other optometrists as well and the discussion and debate element of it.
It was a huge confidence builder for me to have instant feedback from an ophthalmologist that many of my provisional diagnoses were correct, and it also gave me the confidence to go on and construct a management plan that I would use to treat the individual patient.
There's no better teaching aid than actually having patients with prevailing conditions and having the comfort and reassurance of a trained ophthalmologist there to make sure that you're on the right lines and that you're picking things up well.
Compliance is obviously a very important part, and again I come back down to my view of regular aftercare as being one of the ways that you, one, check compliance and then two, try and induce good compliance from the patient.
I get them to talk through it. I get them to talk through what they do exactly. I will have got them to take their lenses out anyway, so I'll see if they wash their hands or whether they're one of those people that sit in the chair and just pull their lenses out, right? So I'll be looking for that anyway, and then I'll cover it again. And at that point again, I'll just re-emphasise how difficult is this? How easy do you find this to do? Is it really routine in the evening, or is it something you think, oh God, I've got to go through this cleaning again? What is it about? So I'm trying to make lens wear as easy and comfortable as possible. So I don't want to make it look like an arduous task. So, Yes, I want to make sure they do it properly, but I don't want to make a big deal of it either.
I always ask my patients to demonstrate their lens cleaning, go through the processes that they do. My experience, for example, is part of the routine is not necessarily the rubbing, but the rinsing stage is something that I've often found, that they actually go through a full rub, but don't then rinse the lenses off before they put them in the case. So you can then reinstill that particular piece of advice.
There's a tendency to hand out leaflets, and I tend to not be very good with leaflets myself. But if I've got something stored on my phone or on my computer, I can go and look it up. So I've said to a couple of patients, would you like me to send this through to you in a PDF format? And everyone's just gone, yes. So it's much easier than scratching around your bag for a piece of paper when you've got a lens stuck in your eye and you can't remember quite what to do.